Assalamualaikum doctors. In this video I am discussing bronchial asthma. Asthma video stations. It usually come with adolescent child and taking maybe peak expiratory flow meter surrounding respiratory distress, tachypneic child or inhaler taking something. So asthma, what is the DD of exacerbations? It is an asthma with exacerbations. We tell the diagnosis. The DD we can keep like non-compliance to the treatment, wrong technique, inappropriate dose or storage, triggers are still there, wrong diagnosis and other types of allergies coexisted. What are the history we ask? First of all, onset, course and durations, what exacerbate and what relieves. And for the what exacerbate and what relieves. One thing, the mild, moderate severity, we can ask like, can he complete sentences? Is he become cyanosis, pale or? Then usually the trigger like exercise, food and psychological. Frequency of attacks is need for reliever, inhaler. Then other allergies like eczema, allergic rhino, conjunctivitis, food allergy and anaphylaxis. Growth and development, weight and height, family socioeconomic status, home environment, other family members, vaccination status, school performance, daily activity. Diary of the symptoms like peak expiratory flow rate, revise inhaler technique, home management plan, compliance to treatment and psychological. Is it first time or recurrent occur, daytime or nighttime cough, inhaler technique, dose, compliance, steroid side effect, is there any smoker in the home, pollen, dust, pet, gardens, maintain the diary and team of following. And what examination we do, ABC, oxygen saturation, hydration status, capillary fill time, consciousness level, chest examination, peak expiratory flow rate if older than 5 years, general examination for sign of steroid toxicity and Cushing-Goid features, weight and height, plot on the growth chart. The investigation we do are mainly clinical diagnosis, chest x-ray, if the patient in life-threatening asthma, fever without focus, any concern regarding foreign body. ABG, urea and electrolyte, hypokalemia after salbutamol infusions. So this is the investigations. Okay, I am telling again, then before going the management, this is that asthma, that is an acute exacerbation of asthma diagnosis we tell. The DD we can keep like non-compliant to the treatment, wrong technique, inappropriate dose, triggers are still there, maybe incorrect storage, wrong diagnosis and other types of allergies coexisted. What history I ask, onset, course and duration, what exacerbate and what relieves. Can he complete sentences, cyanosis and pallor, usual triggers, exercise, food and psychological, frequency of the attack, number, need for reliever, inhaler, other allergies like eczema, allergic rhino, conjunctivitis, food allergy and anaphylaxis, growth or development, weight and height, family socioeconomic status, home environment and other family members, vaccination status, school performance, daily activity, diary of the symptoms, peak expiratory flow rate, revise the inhaler technique, home management plan, compliance to treatment, psychological. Is the cough is first time or recurrent occur, daytime or nighttime, inhaler technique, dose, compliance, steroid side effects, smoker, pollen, dust, pet, garden, maintain diary and team following. Examination are AVC, oxygen saturation, hydration status, capillary refill time and consciousness level. Chest examinations, peak expiratory flow rate if older than 5 years, general examination for sign of steroid toxicity and Cushing-Goid features, weight and height and plot on the growth chart. Investigation mainly clinical, chest x-ray we can do, ABG we can do because hypokalemia is the side effects of salbutamol. So how can we manage an asthma patient? First of all, mild, moderate, severe life-threatening conditions. These are. So mild to moderate, first of all, the criteria are normal vital signs. Mild who is speaking in complete sentences or feeding, SpO2 more than 92% in air and peak expiratory flow rate more than 50% in those age more than 5 years. So more than 92% SpO2 and more than 50% PEFR. First of all, we are giving salbutamol 2 to 10 puff, okay, via a large volume and spacer, plus minus face mask. Then oxygen if SpO2 less than 94% in air. Once daily oral prednisolone if on maintenance therapy, discuss with the respiratory consultants. Then age less than 2 year, maximum 10 mg once daily, age 2 to 5 year, maximum 20 mg once daily, and age more than 5 year, maximum 30 mg once daily. Then reassess every 15 to 30 minutes and discharge criteria is SpO2 more than 94% and peak flow more than 75% predicted and stable for 4 hour inhaled treatment. Yes, discharge home. Continue once daily oral prednisolone, complete a 3 to 5 days course, review long-term asthma control plus treatment, check the inhaler technique, provide PAP agree follow-up plan and complete the respiratory discharge letter discharge. So mild to moderate, first of all, we are giving salbutamol inhaler 2 to 10 puff. After that, we are giving some steroid for 2 to 3 days for reduce the inflammations. This is the treatment of oxygen if less than 92%, 94% in air. So that is the treatment. Then we are discharging when saturation more than 94%, peak expiratory flow more than 75%, heart rate, respiratory rate according to age come stable 4 hourly. Then we are discharging, giving the advice. Now what about the moderate? Severe case, it is mild to moderate, I already told. Severe case, too breathless to talk. So too breathless to talk or feed, so SpO2 less than 92% in ER, use of accessory muscles, and peak flow less than 50% predict. So oxygen via mask, first of all we are giving oxygen because saturation is less than 92% here giving. Oxygen via mask by nasal cannula, salbutamol 10 puffs we are giving by a large volume spacer or face mask. Then salbutamol nebulized driven by 6 to 8 liter per minute oxygen. If poor response, give ipratropium bromide nebulized once daily, oral prednisolone if on maintenance therapy. Discuss with respiratory consultant nurse. If oral steroid not tolerated, give hydrocortisone by slow IV injection age more than 1 month, 4 mg per kg 6 hourly. Okay, then discharge. Continue oxygen via mask or nasal cannula, nebulized salbutamol. Repeat the ipratropium bromide. If poor response, give every 20 to 30 minutes for first 2 hours. Reassess the frequency of the bronchodilator therapy and symptoms improving, then we discharge. So it is severe case, saturation less than 92, PEFR less than 50%. So what we do, first of all, we are giving oxygen via mask. Salbutamol inhaler we are giving, nebulized salbutamol inhaler we are giving. If needed, hydrocortisone we are giving. If not improving, we are giving ipratropium bromide. Okay, so this is the mainly treatment, and oral steroid we can give once improve conditions. Then we are discharging according to discharge proforma. Now life-threatening case. Life-threatening case, the child is cyanosis or failure, silent chest, poor respiratory effort, altered the consciousness, SpO2 less than 92% in air, and then irritable. The person is peak expiratory flow rate less than 30%. What I do, I will give oxygen. Continuously inform on call my consultant, I will involve, and the PIC will go. Oxygen by maintenance and dose, then salbutamol nebulized driven 5 to 8 liter per minute with oxygens. Ipratropium bromide we are giving, hydrocortisone slow IV we are giving. Sign of shock, sodium chloride 0.9% 20 ml per kg IV bolus I am giving. Then not improving, we are salbutamol IV we are giving. Consider magnesium sulfate IV, and blood gas chest X-ray we are doing. And then we are record the heart rate, respiratory rate every 10 minutes. Continue SpO2, carbon dioxide monitoring, ECG monitoring, baseline urine electrolyte monitoring. So this is severe cases of bronchial asthma. When I diagnose that, like the child is silent, not effort to talk, the time peak expiratory flow rate less than 30%. I will give the oxygen, the nebulized salbutamol, ipratropium bromide, hydrocortisone IV. Then we are giving, if shock, 0.9% sodium chloride 20 ml per kg. If this is not important, IV salbutamol we are giving, IV ipratropium bromide. Continuously monitoring the ECG and the ECG saturations, ABG, electrolytes. These are we will monitor. So this is all about the asthma management. Now talking about the step up, step down management. So in step up and step down management, actually it is less than 5 years of age old we include, and more than 5 years of age child we are including. So first, less than 5 or more than all the children we are starting with salbutamol, that is long short acting, that is salbutamol inhale beta inhale SABA, short acting beta agonist. Okay, of our first short acting beta agonist. Short acting beta agonist is not actually working if asthma is uncontrolled 4 to 8 weeks. Then we consider 8-week trial of pediatric moderate dose inhaled corticosteroid with the SABA. If SABA is not improving, okay, stop the inhaled corticosteroid after 8 weeks and review the response. So if the symptoms not resolving, then offer pediatric low dose of inhaled corticosteroid with SABA. After that, consider low dose of inhaled corticosteroid plus leukotriene receptor antagonist with the SABA. Then leukotriene antagonist is not going working. Then stop the leukotriene antagonist, but continue with the pediatric low dose inhaled corticosteroid. Long acting beta agonist also we give. Then refer to the healthcare professional with expertise in asthma for further investigation and management. Consider decreasing the maintenance therapy when asthma has been controlled with current maintenance therapy for at least 3 months. So after 3 months we will be considered. Some advice we give asthma discharge patient. What is the asthma? Avoid the trigger, dust, mites, cold weather, pets and smoking. Using your inhaler correctly. Diary of the symptoms and PEFR. Number 3, exercising regularly, eating healthy, getting vaccinated. Annual flu vaccine and pneumococcal vaccinations. On traveling, make sure you have enough medicine with you and keep your reliever inhaler easily accessible. Stuck to your follow-up visits regularly. Always remember asthma action plan and call ambulance if you feel worse at any time and if in red zone or yellow zone and getting worse. So this is all about bronchial asthma video station. Thank you.